Chris Wallis. I'm glad to be here from ASCO 2023 talking with Dr. Karim Fizazi, who's presented some late-breaking data from the TALAPRO-2 study. Thanks so much for joining us today, Dr. Fizazi.
My pleasure. Thank you for having me.
Of course. So if you can maybe help us understand, many of the members of the audience will have known Dr. Agarwal's presentation at GU ASCO with the preliminary results of TALAPRO-2. How did the data presented today differ from what we've seen before?
Right, sure. Happy to explain that. And you're right, it's a bit complex because basically TALAPRO-2 is not just one phase 3 trial, but actually two phase 3 trials in just one study. And I'm saying that because we tested the same hypothesis, talazo plus enza superior or not versus enza alone, in two different categories of patients. What Niraj showed at ASCO GU was the cohort of patients which we call all comers, including men with and without homologous recombination alterations. The trial is positive. The paper, by the way, is out today in the Lancet Journal. But we also had a different cohort which was kind of independent, if you will. I'm saying that because when the accrual of the first 800 men from the all-comer population was completed, we stopped the accrual of all-comers, but we carried on with more patients with DNA repair defects. And actually we enrolled an additional 230 patients for a total of almost 400 with DNA repair defects. And this is cohort 2, which is the one I presented today. So it's really focusing on patients with DNA repair defects.
Right. And so it's almost a methodology a little bit between PROPEL and magnitude. You can think of it, right, with a little bit of biomarker selection before randomization.
Yes, definitely. And we, the DNA repair status was informed by both tissue and ctDNA. The tissue was available in 98% of cases, and it was this was tested prospectively. So we had the information before randomization, as opposed to PROPEL, for example, where it was really more a retrospective analysis. So I think this is a straight of the trial because we really stratified based on the HR status.
Absolutely, and if you can sort of walk us through the results of what this cohort 2 of TALAPRO-2 showed, and maybe contrast it with the all-comer data and help us really understand that benefit of patient selection.
Yes, so the primary endpoint of the trial is radiographic progression-free survival, and it was clearly met in this population of men with a 55% reduction in the risk of progression or death. When digging into more details regarding gene alterations, what we saw was that patients with BRCA alterations tremendously benefit from the combo with a 80% reduction in the risk of progression or death. Another good news comes from this kind of sub-analysis between BRCA1 and BRCA2, because I know some of our colleagues are struggling as to whether they should treat their patients with BRCA1 alterations with a PARP inhibitor. Here in our trial, the hazard ratio was 0.17, 17 for BRCA1, very similar to BRCA2, 0.19, so more than 80% reduction in the risk, which is impressive. Another good news came from the CDK12 analysis. Typically, aggressive cancers, we don't have so many options for these men. And here in TALAPRO-2, they tend to benefit from the combination of a PARP inhibitor plus enzalutamide with a clear separation in radiographic progression-free survival and a hazard ratio of approximately 0.4, so almost a 60% reduction in the risk, which is a new finding, I guess.
Absolutely.
We also had, or at least we also had a look on overall survival, which is a key secondary endpoint. It's an interim analysis right now. The data are not mature. More than 75% of men were alive when we did the analysis. Still, we see a clear trend favoring the combo with a 31% reduction in the risk of death, almost significant. And we plan to do a final analysis, which is event-driven, but let's say sometimes probably next year. So that is very encouraging, I guess. All secondary endpoints that we tested were also met: response, time to PSA progression, which is so important to patients psychologically, but also PFS2. Time to chemotherapy was also significantly improved. Having said that, the price to pay from a patient perspective, from a toxicity perspective, is really mostly the anemia,
Right.
with a 40% grade 3 or 4 rate in the experimental arm, which means also transfusion for many of these men, and dose reduction for talazoparib to carry on. Having said that, we haven't seen any myelodysplasia case or any leukemia case, which to me is very reassuring. I was fearing that. And the level of the incidence of pulmonary embolism was rare, was very low, 2% versus 1%. And again, when I saw the Propel data with 7%, I was, fearing something, but we haven't seen that in TALAPRO-2. And last but not least, quality of life, which kind of merged the efficacy and safety information on top of other things, obviously, is significantly improved, also favoring the combination, with 31% reduction in terms of time to deterioration in quality of life, which I think is clearly telling us that we are helping patients. Before we have overall survival data, this is clear signal to me that it's not just an image thing. We are directly changing the natural history of disease.
Absolutely, and we have to weigh the disease progression and the ability to benefit that against the toxicity of therapy. And I think that quality of life data really highlights that when you weigh those two, and the balance of it really favors that earlier intervention. And so I'm wondering your thoughts. Recently in the U.S. we've seen approval of the olaparib and abiraterone combination in a very limited subset of the BRCA1, BRCA2 men. Your data support that that's a really subset of men that get a profound benefit from this PARP and ARSI combination, but it seems that a wider selection of men may benefit. And so your thoughts on what is the right subgroup for us to be looking at here?
It's obviously a difficult question, and it's striking to me to see that the FDA and the EMA made two different decisions regarding this question. Actually, the reverse way as compared to what you typically see.
Or profound even compared.
Yeah, so the FDA was much more conservative, as you just said, BRCA patients only, while the EMA was more liberal, and that's more the all-comer population. There are clearly pros and cons, so I can really understand the two decisions, to be honest. I think most important is that BRCA2 and BRCA1 patients should be treated, and should be treated early. I think this is the main message. Regardless what we think about the debate for the all-comers, the main message should be test your patient. If he's a BRCA1 or BRCA2, you should treat him with a PARP inhibitor probably as soon as possible for CRPC. And next generation trials will inform us as to whether we should also use PARP inhibition for castration-sensitive disease, which I think is a key question. Now, for non-BRCA patients, I think we need probably even more data, to be honest, because it's really a balance between efficacy and safety. Frankly speaking, I think, of course, I'm not an advocate, but I think the FDA people would perhaps have made a different decision if the toxicity would be 0, given this level of efficacy. But you really have to balance. 40% transfusion rate, for example, is not nothing clinically, but also for the hospital, for costs, for other things. So I think this is also a reasonable decision right now, not meaning that in, say, a year from now or 2 years from now, when we have complete maturity from these trials, the two agencies may actually fine-tune their decision and revise it if we demonstrate clearly that patients without BRCA alterations clinically benefit by quality of life, or by overall survival, strong clinical endpoints, which I guess you and me would like to see for our patients.
Absolutely, and I think one of the key messages you highlighted in that in that response was the importance of testing these patients, right? So we're talking about making these treatment decisions, knowing the biomarker status of these patients. And I think, it's not a given that all these patients are getting their biomarker testing. And that's really, a key message early on in the advanced prostate cancer trajectory of these patients, is to make sure we understand their biomarker status and really have that opportunity to identify the BRCA1, BRCA2 men earlier, so that we can make those intensification decisions.
I agree, and I guess this is an important message, not only medically speaking, but also for the insurance or for the social security system that you and I have in Canada or in France, that all the systems should find their way to cover the cost of a test, just because it's worth it for patients. And I think, again, this is really a very practical message.
Absolutely. Well, thank you so much for your time today, and congratulations again on the big talk this morning.
My pleasure. Thank you so much.
Thanks so much.